Thank you, Dr. Iyer, for your kind words of introduction, and Telavaid team for the invitation. Am I audible?
Yes, we can hear you.
Yeah. So again, as you well pointed out, we are in a perfect storm with mucormycosis in India, and and I'm happy to talk to you more about this problem and helping understand what might be going on. I don't have any disclosures. I want to acknowledge my mentor, Dr. Kuntianos, who has been like phenomenal in guiding me through this process. So the outline will be on like a brief introduction, epidemiology and pathogenesis, and key aspects in diagnosis and treatment. So this is a teleconsult I got from Hyderabad, a 35-year-old, my friend's nephew, 35-year-old man from urban Hyderabad. He was a software engineer. He was working from home during the COVID pandemic. He had a mild COVID-19 infection in April of 2021. No other comorbidities, perfectly healthy, no obesity, no other chronic risk factors. He was started on steroids. He was given in oral methylprednisolone, followed by prednisone that was given around for 3 weeks. He presented 4 weeks later with a tooth pain, and that was progressively getting worse. MRI showed bilateral sinusitis. He underwent sinus surgery and tooth extraction. The patch showed the presence of mucor, which was confirmed in culture. He was initially started on isovuconazole, which was changed to amphotericin B after 3 days, and then he was discharged after 1 week of therapy. And he again now comes back 1 month later with worsening symptoms, and now there is involvement of the right orbit. So the question was what to do, and hopefully we'll be able to answer that by the end of this session. So what are mucorales? Mucorales are ubiquitous organisms. They found in the environment, and they found in the environment. It releases spores, and that's how humans get the infection. They are opportunistic, meaning that it rarely causes infection in an immunocompetent host. Human infection was very rare before the pandemic of COVID-19 and epidemic of COVID-associated mucormycosis. They are a frequent contaminant in laboratory, so we have to be very careful in assessing a clinical sample. Sometimes difficult to grow in culture because of the nature of the organism. The characteristic property of this fungus is its angioinvasiveness and its ability to cause tissue destruction and dissemination within a span of like a day or two. And it is associated with that results in high morbidity and mortality. Just to show you the different species, the commonest one being Rhizopus and Mucor. And the background rate of mucormycosis, this is a nice description just to highlight that mucor is prevalent all across the globe. And this is an underrepresentation of the number of cases because this is based on the number of reported cases. And India, before the pre-COVID era, had around 89 cases per year. There was an increase of 25 cases per year over the last decade. The prevalence is noted to be around 14 cases per 100,000, which is definitely 70 times higher than the global burden of the disease. And India is considered a hot tub of fungal infections. Indian ICUs, the rate is slightly higher, 14%. And main mucor they see, one of the forms they see is pulmonary form. And the common risk factor in the Indian population was uncontrolled diabetes mellitus, where mucor unmasked diabetes mellitus in half of those patients. The commonest form of disease was Rhino orbital cerebral disease. And isolated renal mucor is a unique entity that is found only in India and China, or at least being reported from these countries. And Rhizopus and Apophyzomyces are the commonest species that you see in Indian population. Here we see that in an immunocompetent host, usually cutaneous and isolated renal form. Some of the unique risk factors in the Indian population include chronic kidney disease, history of pulmonary tuberculosis, and COPD. It is also important to note that we have isolated the pathogenic species of mucor from the environment. In this environmental study done in North India by Dr. Prakash et al., they found that the spore counts in the atmosphere changes with the states and the season. And in Haryana, it usually correlated with the agricultural season where there is more dispersion of the organism from the soil. And there was a positive correlation between moisture and fungal growth. Whereas inside the hospital, they found a higher rate in hematological ICUs and in the emergency rooms. And overall count was more in non-AC rooms compared to the AC rooms. And this is another study from University of Washington and MD Anderson, where they looked at the role of geoclimatic conditions. As you can see here, this was a time period when they had a peak in the cases, and it correlated significantly with an increase in environmental temperature more than 20 degrees Celsius, although they could not find any correlation with the precipitancy. Sorry, the red line indicates the environmental temperature, and the blue line indicates the precipitation pattern. No correlation with the precipitation, but significant correlation with the temperature. COVID-associated mucormycosis, although it is reported from many countries, including North and South America, it is a major problem in India right now. There is no official counts, so what information I got is from this website and then the Twitter account of Dr. Gowda, our union minister. So these cases are climbing, like it seemed to have plateaued around like 30,000 plus cases as of now, and the deaths are underreported. So total COVID cases, this is from a recent publication from the Ophthalmological Society. As you see on the left, you see the total number of COVID cases. I feel that this is also an underrepresentation because Kerala stands with the highest number of positive cases for COVID. And this is the COVID-associated mucormycosis. As you can see, seems to be more common in Gujarat and Maharashtra, Telangana and parts of like Andhra Pradesh, and with other cases being reported in Madhya Pradesh as well. So a brief outline of the pathogenesis. It is important to note this. There is a specific ligand on the fungus called the cortege, or the spore coating protein, which attaches to a receptor cells on the nasal epithelium. Although all patients get the infection through inhalation, the next steps are different here. So in patients with DKA, where they seem to have more Rhino orbital disease, there is more the nasal GRP78, or the glucose regulated protein 78, is a main receptor. But for the immunocompromised host, where the pulmonary mucor is common, the receptor for this attachment is integrin beta 1. This is courtesy of a beautifully done study by Dr. Ibrahim et al. At UCLA, where they found that this is the particular reason why DKA patients develop this the Rhino orbital disease more. And on the right, just to show you the different the environment or the milieu for the fungal growth, the acidifying factors increases the delivery of iron to the mucor. The beta hydroxybutyrate that you see in ketoacidosis by affecting the host immunity, it also affects the host immunity as well as increase the expression of GRP78, and everything like feeds to the growth and attachment of the virus and its angioinvasiveness. Just to summarize, like diabetes, the main players are diabetes, presence of heme from like iron from heme, use of steroids. I want to highlight one point is that DKA, or diabetic ketoacidosis, does not predispose to aspergillosis. So there is something like that is specific to mucormycosis, and also the pleiotropic effect of steroids. We know that it can cause functional neutropenia and functional lymphocyte deficiency, and there is a risk associated with high dose of steroids. So what is a molecular pathway where a virus and a fungus kind of converge? As you see here, the GRP78 seems to be a critical player in SARS-CoV-2 pathogenesis also, because it is important for the viral attachment and entry, viral protein production, as well as the release of the virus from the host cell. So although many other factors may be possible, there is a one plausible way of correlating these two infections together. Just to highlight some key the characteristics or how you classify the disease, it can be classified into a community-acquired onset mucormycosis as well as a nosocomial infection. The nosocomial infection part is difficult to diagnose because, again, we don't have a strict criteria. This is one of the criteria they used in one of the publications where they diagnosed it as, where they called it as if a diagnosis is made 2 weeks after admission or within 2 weeks of discharge. But something to keep in mind, especially when you see an abnormal cluster of cases in your hospitals. And this is a guidance of like definition of invasive fungal disease. Just to want to highlight that for a proven disease, we need to have tissue damage or we need to show the culture positivity from a sterile aspiration or a sterile biopsy. Everything else falls in the probable or the possible spectrum. One thing also to highlight is that the presence of the mucor in bronchoalveolar lavage is not consistent with the invasive disease, as this could be a contaminant or it could be an airway colonization, and everything else falls in the possible category. The clinical types, they are broadly divided into Rhino orbital disease, pulmonary disease, gastrointestinal, cutaneous, disseminated, based on the how the organism gets into the body by inhalation, ingestion, implantation, or inoculation. And just to highlight the process, angioinvasion, dissemination, and organ involvement. Before I finish, just to highlight this mucormycosis scenario, this was a publication from Patel, Dr. Patel et al. That was published in the CDC journal. As you can see, COVID-associated mucormycosis are even seen up to 120 days of the diagnosis of COVID-19. And just to highlight the key findings, in a minority of patients, they were not on any steroids. So there is something else that may be playing a role. The cumulative doses of steroid was significantly higher compared to the recommended doses, and appropriate steroid use was only seen in a minority of patients. And like in other previous studies, we see there is a lot of like new onset diabetes mellitus and DKA, and main presentation was Rhino orbital or Rhino orbital cerebral disease. So with that, I will end my presentation here, and I will give back to Dr. Iyer. Thank you.
Thank you, Dr. Teny John. Dr. Srinivasan Sanjay, I think you should go ahead with your presentation. Right.
You're muted, Sanjay.
Hi. I'd like to thank Swami, whom I've known for last 30 years, and also Telavaid for giving me the opportunity to share our work. So let me share my screen. Is my screen visible?
No.
Not yet.
Now?
Yes.
Yes.
Great. So let me talk to you briefly about the ophthalmic manifestations of mucormycosis. Basically, it's the domain of ENT and the neurologists, neurosurgeons. We are stuck in between in the orbit. Why mucormycosis and COVID? Dr. Teny has very nicely in his presentation conveyed how mucormycosis can affect in COVID patients. I would like to summarize in this single slide So SARS-CoV-2 basically breaks the epithelial barrier in the nose, and there is dysfunction of macrophages. There is pancreatic involvement. Many people are becoming diabetic after COVID infection. This hyperglycemia in turn also impairs the neutrophil defense. The role of cytokine storm with reactive oxygen also causes dysfunction of the macrophages, which also causes iron overload, which is very much beneficial for the fungi. There is also reduction in the platelet-derived growth factor, which is the first line of response against the fungus. So these four mechanisms actually play a role in COVID patients developing mucormycosis. So this slide was shared by Dr. Teny. So basically the west of India is affected by COVID associated mucormycosis. This graph is from the COSMIC study, which was published about 2 days back. So I'll be sharing some of their findings and some of our findings. So basically it is a Rhino orbital cerebral mucormycosis. Several risk factors have been identified like diabetes, steroids, the role of tocilizumab, mechanical ventilation, and probably oxygen therapy has a role. So in this study, COSMIC study, they looked at patients who were hospitalized were more likely to actually get mucormycosis. Role of oral corticosteroids was also there. Remdesivir surprisingly was implicated in initial days, but they found out in this study that remdesivir had no role. Tocilizumab also probably not much big role. Oxygen administration through mask and prongs, probably contamination with water probably helped this mucormycosis. When we look at ophthalmic considerations, there are a wide range of symptoms and signs. The patient can present with facial pain, stuffy nose, with a headache, decreased vision, blood stained nasal discharge, and toothache. These can be in varying degrees or in combinations which can actually cause the patient to present to an ophthalmologist. The signs include swelling of the face, ptosis, which is drooping of the lids, proptosis, prominent eyeball. There may be restricted motility, orbital cellulitis, central retinal artery occlusion, which actually causes the patient to have vision symptoms. More serious forms include panophthalmitis, palatal and nasal eschar. So in the COSMIC study, they actually found out that the orbitofacial pain and the orbitofacial edema were one of the common symptoms which the patient actually had. The primary sign again included swelling of the face, and loss of vision was almost seen in a quarter of patients because of the central artery occlusions. There were other symptoms like double vision and restriction of motility, proptosis and ptosis. This is one of our patients who had proptosis with ptosis with swelling of the lids, lid edema and erythema around the eyes. On lifting up the lid, the eyeball was frozen. You can see that pupil is dilated. There's a lot of congestion and chemosis. One of our other patients had blackened tissue in the nose and palate. This is the endoscopic view where you can see the eschar, and the pink colors are the normal turbinates seen through the endoscopy of the nose. One of the unfortunate patients who had central retinal artery occlusion, characterized by a pale optic disc, cherry red spot in the macula with whitening around. This patient actually lost the vision. Even though it has been variously termed black fungus, the fungus is actually transparent septate fungus. Reaction it causes in the body causes it to be called black fungus, even though it is not. So in Narayana Nethralaya, we have the molecular diagnosis of mucormycosis, where we do not need to wait for probably a growth of a fungi. We use this PCR. This is one of the patient's PCR. We actually have this blue sigmoidal peaks, which are the internal control. The positive one is the one on the top, and this is another positive control. The positive One on the top is actually the patient, and the other one, red color, is a positive control for the PCR. So imaging, I believe Dr. Rajiv Gupta will be speaking on. So we rely on MRI, brain and orbit, and PNS. The ENT guys actually rely on CT PNS. This is basically used to stage the disease, whether it is Rhino orbital or Rhino orbital cerebral. So we have classified this mucormycosis into three categories. One is a possible mucor, where there are all signs and symptoms. Especially this is helpful in a probably primary or a secondary care setup where you don't have all the fancy equipments like MRI, CT, or other diagnostic modalities. The probable diagnosis is the possible with signs and symptoms with ENT involvement with the diagnostic endoscopy and diagnostic MRI, and a proven case of mucormycosis where you can histopathologically or microbiologically confirm the diagnosis. So the MRI imaging signs, what we actually see include periosteal thickening, enhancement of the bone trigone, fat stranding, medial orbital abscess, thickened extraocular muscles, and globe tenting. Globe tenting is one of the important signs we actually see. There has been this paper again published in the Indian Journal of Ophthalmology 2 days back. So this actually shows what are the things you need to look for in different places, like the rhino sinus, extra sinus, bone, orbital, vascular, CNS. So in some of our cases, we have seen superior venous thrombosis as one of the things, ophthalmic vein thrombosis as one of the early signs. This patient had hypo with a surrounding enhancing rim indicating invasiveness of the mucor. I'll be sharing you three interesting cases which probably made us think whether this was mucor or not. The first patient was a 59-year-old Asian Indian male. He was referred to as a right orbital cellitis. He had history of pain for about 15 days and redness of eye for about 4 days. Interestingly, he had first dose of COVID vaccination in the month of March and the second dose in the month of May. Prior to his symptoms in the eye, he had Covishield vaccine, and MRI of the brain with PNS showed minimal mucosal thickening in maxillary sinus. The orbit was normal. He was a known diabetic, hypertensive, and a smoker. So this is his picture. So now this picture basically scares everybody. The medial involvement with this kind of swelling makes us think whether it's a mucor or not. This is the ultrasound B scan which I did, and it showed thickening of the orbital and the intraocular structures with fluid. His ESR was about 16, CRP was negative. In this patient, interestingly, he had both SARS-CoV-2 RBD, that is receptor binding domain antibodies, and the anti-spike SARS-CoV-2 IgG antibodies, which usually occur after Covishield, and his fibrinogen level was about 409. RT-PCR for COVID-19 was negative, and the chest X-ray had bronchiectatic changes in bilateral lower lung zones. So were we dealing with a patient with COVID-19 who was asymptomatic, developed mucor, or was it something else? So this is this fundus photography, wide field fundus photography showing swelling inside the eye, which is a choroidal swelling. I'll show you the video. It shows swelling beneath the choroid. You can see how high the spike is, showing that there is a reasonable amount of push on the sclera and in turn on the choroid, causing the swelling, which is reflected on the fundus examination. Subsequently, we got a ENT evaluation who basically ruled out mucor, and this patient was put on high dose steroids, and lo behold, the swelling actually reduced significantly, and patient was also symptomatically better. And as ultrasound scan, which actually showed intraocular and extraocular swelling also reduced. Coming to patient 2, patient 2 was a known diabetic and hypertensive on medications. He was a 43-year-old Asian Indian male. He had a history of recurrent redness in his right eye 4 months earlier prior to this episode. He had a history of Covishield vaccination in the month of May last week, and subsequently he developed more redness, pain, and swelling in the right eye. This is his picture. You can see the lid edema, lot of congestion and chemosis. You can see here some dilated blood vessels. Again, this patient had high COVID antibodies with anti-spike antibodies correlating with the vaccine. Again, his fibrinogen level was increased. Again, X-ray showed some patchy area of pneumonia in the right lower zone. Here, you can see there is a hypofluorescent area behind the retina. This is called subtenon's fluid. Again, there's something happening in the scleral area. And this is his X-ray showing the lower zone patchy thing and some linear fibrotic bands. We did a MRI. MRI showed mucosal thickening in the right maxillary sinus. The right lobe showed a mild proptosis with uveoscleral thickening. The recti muscles were enlarged and optic nerve was normal. Here, the confounding factor was right superior ophthalmic vein, which appeared congested, but there was no evidence of thrombosis. So now we sought a ENT and a rheumatologist opinion. ENT again gave clearance saying that there was no evidence of mucor. The rheumatologist thought whether it was a granulomatous polyangiitis. We kept the diagnosis of a thyroid eye disease, low flow CCF, possibility of lymphoma. He was started on oral steroids. He's still being investigated though. After 1 week of steroids, there was subsequently a reduction in his swelling and his lid edema. Coming to the patient 3, this is one of the more interesting patients. It's a 57-year-old Asian Indian female who presented with presumed bacterial endophthalmitis in 2019 and was treated with intravitreal injections. Again, she was a known diabetic and a hypertensive. Her second dose of Covishield was in 8th of May, and she was diagnosed with COVID-19 pneumonia. So this means to say that Covishield probably has some effect in reducing the COVID symptoms, but people can actually still develop COVID and COVID pneumonia. Subsequently, she developed left cheek pain and numbness, and she was treated for fungal sinusitis elsewhere. And these were her MRI pictures, which showed enhancement in the maxillary sinus and extending into the left retroantral region. And however, there was no extension into the orbit or cavernous sinus. So it was mainly a ENT problem. And subsequently, I saw her. And after she had undergone sinus debridement, this is our latest picture. If you see, still there is some amount of medial canthal swelling post-op after the sinus debridement. There is asymmetry of her face. Other than that, there are no other signs of mucor in her. So coming to the treatment aspect, what do? We actually treat all this patient with liposomal amphotericin in consultation with our infectious disease colleagues. Liposomal amphotericin is a very scarce commodity in India. Somehow we try to source with many authorities, and we try to provide for the patient. The mean duration would be at least 9 days, wherein we actually step down with a combination of, because it is scarce, we actually try starting them on posaconazole. The treatment of choice is the domain of a ENT surgeon, where they do FES or paranasal sinus debridement. Fortunately, many of our patients, and even in this study, they did not need to undergo orbital exentration, which is quite disfiguring and also causes a lot of psychological manifestations in these patients. And many of these patients are okay with FES or orbital exentration. And intraorbital amphotericin is not required in many of these patients. And if we need to give intraorbital amphotericin, it is roughly about 2 or 3 in probably 2 to 3 days duration. Again, coming to the COSMIC study, which was published recently, again, amphotericin is the main drug of choice in all these patients. So summarizing the management, we have a medical management and a surgical management. Liposomal amphotericin, as I mentioned, is the main choice for treatment. And when it's not available, we try the bridge therapy, wherein we give both amphotericin and oral posaconazole. Then we switch over to oral posaconazole. All patients with suspected mucormycosis undergo sinus debridement. Some cases where it is restricted only to orbit, we try this transcutaneous retrobulbar amphotericin in 3.5 milligram dose, and orbital exentration is done only in patients with severe involvement. In the COSMIC study, it is heartening to know that almost more than close to half of the patients are alive, and they have regressed, and also they are stable. And final visual acuity, unfortunately, is not that much great. We have been able to salvage vision in many of them. So this is a flow chart which indicates what you probably need to do in patients with Rhino orbital and Rhino orbital cerebral mucormycosis. Thank you.
Thank you so much, Dr. Srinivasan. Next, we will move on to Dr. Rajiv Gupta, a neuroradiologist from Massachusetts General Hospital, who will go over more of the radiologic findings with mucormycosis.
So, Sanjay, could you stop sharing?
Just a minute, sorry.
Are you able to see my screen?
Yeah.
Excellent.
Yes.
Okay. So I'll take maybe 10 minutes to talk about some radiologic findings. Some of the topics were already, some of these themes were already covered, so I'll go a little bit fast. We're talking about mucormycosis, but this is a family of fungal diseases. As was mentioned, it is prevalent in poorly controlled debilitating disease, poorly controlled diabetes, immunosuppression, and serious trauma. And here we are really talking about immunosuppression along with diabetes as the main sort of culprit in our case. So as was mentioned, there are multiple different fungal organisms that are possible, but most of the times it's really mucor that is what has been the main cause. And it typically begins in as a fungal sinusitis, and radiologically it is indistinguishable from most other forms of sinusitis you will see. So radiology can be sensitive, but sometimes not very specific. You have to have an alternate diagnosis till you start seeing very late disease where you are actually seeing the invasion, as was mentioned. So it directly invades sinonasal cavity, and then from there it goes to the surrounding areas. So I'll go over a little bit of the anatomy of this region. And then there is, because it is angioinvasive, it can get into the blood and then get into the surrounding areas. And there can also be hematogenous spread from the lungs, which is also mentioned. So the fungus would invade the vessel wall, will cause a kind of localized vasculitis, and then can precipitate and go into thrombosis and thrombotic occlusions. So these are all the things that it can do in terms of like the acute events, whether it's in the orbit or in the sinonasal cavity or cerebrovascular events. Invasion is the most common thing. It can have orbital invasion. Pterygopalatine fossa, which is right behind your maxillary sinus, is sometimes thought to be a reservoir of disease. That's where the fungus kind of lives and spreads. It can then go further deeper into cavernous sinus, can give you cavernous sinus thrombosis. It can give you a basilar meningitis or acute cerebritis. It can also precipitate strokes and hemorrhagic stroke, which is uncommon. You have also seen abscesses. And all these things are visible both on CT and MR. MR is a more sort of advanced modality. It shows the fungus and the invasion of different tissues better, but CT is a lot more available. And many of the things that we see on the MR can also be seen on CT. So let me just go a little bit over the anatomy. I'll change my pointer so that you're able to see. I'll go to the laser pointer. Yeah. So this is a scan acquired for a different reason. This patient has electrodes, which is what we were tracking. But this is a clean sinus. So you can see the maxillary sinuses. You can see a little bit of the orbit. And as we are going up, this is the sort of the main entrance pathway for the disease. And then it can go to the sides. It can go into the orbits, which are very close by. If you go further back, this is your pterygopalatine fossa. It can go into the pterygopalatine fossa. If you go further up, it can go into the cavernous sinuses. And this is sort of where the main site of entry and the site of involvement is. So there is a surgical grading system. Stage 1 is limited to nasal cavity and sinus. Most of the times, debridement, as was mentioned, is the main sort of curative action there. Stage 2, spelling mistake here, disease involving immediate adjacent areas. So extracorneal orbit, palate, oral cavity, all these may be involved. And then disease 3 is requires significantly morbid surgery. And unfortunately, that has become more and more common. I was on call with some physicians from Sri Gangaram Hospital, Sir Gangaram Hospital in New Delhi, and within weeks, they have probably one of the largest collections of these patients because they are a referral site. The same thing is happening at KEM. And because of the prevalence of the disease, which has gone from a few hundreds a few years ago per year to thousands within a few months, India probably has the largest experience base in the world at this time in treating and managing this disease. So, in fact, we are also sort of learning as to what happens to this disease because we have never seen the type of disease that is happening. So, for example, extension to the pterygopalatine fossa, cavernous sinus, intracorneal orbit, all these things are rare. In my career, before all these things happen, I've seen like maybe 10 cases of these things. And now you talk to your Indian colleagues and they're seeing like 10 a day. So what are the sort of the telltale signs? So there's this old paper, which was published in AJNR, and these are the 7 places where which are, some of them are very sensitive, some of them are very specific, but they should be on your checklist when you're looking for this disease. So periantral fat, both anteriorly and posteriorly, is a very good place to start. Dehiscence in the bone, orbital invasion, which you can actually see because the fat will show fat stranding within this. Septal ulceration because of this disease. Pterygopalatine fossa, as I mentioned, nasolacrimal duct, and lacrimal sacs. So these are the 7 sites of disease that some of them are more specific, some of them are more sensitive. But if you look at them in total, you will never miss this disease. And this paper then went on to say which are more sensitive, which are more specific. The dark color here is sensitivity, the light color is specificity. So all the things that are somewhat superficial, they are more sensitive. That's where the disease enters. And as the disease goes deeper and deeper, then the signs that you see are more and more specific. But you don't have to really sort of think about it. As long as the 7 places are on your checklist, you will not miss the disease. So I'll show you from this paper, old paper, where are some of what are the disease manifestations. And you can see this both on CT as well as in MR. So here we have some mucosal thickening, and you see this fat here compared to the contralateral side. That's a pretty good place for to look for mucor. And aspergillus, actually, any kind of invasive fungal sinusitis will give you this. Again, the entire sinus is invaded. Some of it is actually going into the nasal vault. Here we have extracorneal fat stranding here. So even though it's not an MRI, you can actually quite well see where the disease is. So probably the disease was, this was the site of the disease, and then it has actually infiltrated through lamina papyracea into the extracorneal orbit. And again, we see a small little ulceration within the nasal septum, and that can be another sign. Here we have the nasolacrimal duct involvement. This is probably where the disease started. Then it went into the nasolacrimal duct, and more posteriorly, we have a small periosteal abscess, which is being shown over here. This is the same thing in the coronal view. You can see in the nasolacrimal duct how the disease is invading and is causing all this kind of soft tissue swelling. We see it in the nasal vault here. It's actually pushing into more posteriorly into the choana. We see the same thing over here, where it's gone into the sort of oropharyngeal region. Here we have cavernous sinus thrombosis here. You can see that the cavernous sinus, this is what normal cavernous sinus should look like. It's a venous sinus, it should opacify very well, but here it is not opacifying. That means there is some degree of thrombosis within the sinus. And because of that, there is an infarct that has happened. The infarct has become hemorrhagic, and you can see all that. In fact, in this patient, what you see here, this is the cavernous carotid. The cavernous carotid, because the angioinvasivity of the disease of this fungal organism, it has become thrombosed, and this patient is probably will have all sorts of downstream effects because of this. This is another case where you can actually see it has gone into the epidural space here. So now we have intracranial involvement. Okay, and then the same thing over here. You can see more disease in the pterygopalatine fossa, sphenopalatine foramen. All these areas are involved. So this is what the disease does. It sort of enters within the nose and within the sinuses. You can debride it, and that can be curative, especially when the patient is on appropriate medical management. But if that is left untreated, or if that goes undetected, and many times patients present very late, then you see all these other things, and then the mortality becomes very high, 50% and higher sometimes. And then you can go like further back in here. So all this is the MRI image, a T2 weighted image, and you can see all this dark color is characteristic for this for this fungus. So we call it the evil gray. So all the T2 weighted images will show you this evil gray, which we have to sort of watch out for. And this is obviously a very late case. We already have sort of a well-formed abscess here, and you can see the hemorrhagic conversion of that abscess. So I'll show you one case, 85-year-old. He was a vasculopath, diabetes, peripheral vascular disease, hypertension, presented with 10 days of bilateral vision loss. Noticed bilateral blurry visions maybe 7 days prior to arrival. On the admission day, he experienced complete bilateral vision loss and found to have severe thrombocytosis. So here, this is an MRI scan which shows you actually what is happening here. So you can see this is a DWI weighted image, and you can see there's restricted diffusion within the optic nerve, and it was sort of bilaterally. One side was more involved than the other, and this is what we're seeing here. And I would not belabor the point here, because some of these things have already been talked about. And what is the main culprit here is, once the fungus becomes retroorbital, it can invade the central retinal artery. And this is a diagram that is showing you how the optic nerve is vascularized. So you have the central retinal artery, a part is going anterior, a part is going posterior, and any of these areas can be involved. And there's a whole sort of classification system around it that we don't have to get into. But the fact is, a retroorbital invasion, retrobulbar invasion is a very bad sign. So the clinical course of this was he had anterior ischemia, and unfortunately, I mean, the patient survived, but he did not get his vision back. Okay, this is a case that I received from Sir Gangaram Hospital in New Delhi, and they are seeing every month dozens of these cases. So here is a case where there is much more profound than the case that I just showed you. Complete infarction of the optic nerve on the left side and the same thing on the right side from a site of disease which is probably here. Okay, so very small site of disease. Rest of the things looks relatively okay, except that you have bilateral vision loss here, and this is not going to come back. So in conclusion, be vigilant, look for all this 7 cardinal signs of disease, and these are the sort of checkpoints where you have possibility of finding early signs as well as the late signs. You should note what are the changes on the CT as well as on the MRI. And if you look for all this, then you have nailed the case. So with that, I think I will stop and I will move on to the next speaker.
Thank you, Dr. Gupta, for that oversight of the radiologic perspective on management of and diagnosis of mucor. We're going to transition back to Dr. John, who is going to provide a brief overview on the ID management.
Thank you. In the interest of time, maybe I'll just quickly go to the management. So again, as the other speakers, Dr. Sanjay and Dr. Gupta mentioned, the diagnosis is key, and it's a tough infection to diagnose because there are so many confounding factors. So after we diagnose, the next question is how do you treat? The main the treatment, this study showed that early initiation of amphotericin B makes a lot of difference in these cases. In this, early treatment was defined as less than 6 days from diagnosis compared to delayed treatment more than 6 days, which was so as soon as you make the diagnosis or you suspect there is mucormycosis, you have to initiate the treatment. Then that will improve your chance of survival. Few aspects about antifungal agents being used in mucormycosis. It's the property of the organism is such that it's inherently resistant to many antifungal agents, including voriconazole, echinocandins. There is limited in vitro activity for itraconazole, which has been kind of recently suggested by the Indian community for treatment of mucormycosis because of lack of availability of amphotericin B. Although amphotericin B is the most active agent, responses are kind of very varies from 30 to 71%, and we see resistance and tolerance to this agent. And posaconazole and isovuconazole are the other alternative therapy, as Dr. Sanjay mentioned. And among the different species, Rhizopus and Cunninghamella are the most resistant species and kind of difficult to treat. A few points regarding posaconazole and isovuconazole: they are fungistatic drug, meaning that it does not kill the organism, it just prevents its growth. So it's not a great choice for upfront like treatment of mucormycosis. The backbone of therapy should always be amphotericin B. The problem with the posaconazole is that it has suboptimal absorption, which is related to the food intake. The absorption varies from 54 to 80%, depending on how good a meal that you take. And the steady state concentration for both azoles will take at least 1 week. So again, underscoring the fact that these are not the first line drugs to be given. Always for posaconazole, watch out for the LFT abnormalities, prolongation of the QTC interval and neuropsychiatric manifestations. And drug interactions are always a challenge, especially if the patient is already on medications for transplant or other important underlying conditions. For isovuconazole, again, the main difference is that it's well absorbed. It has a bioavailability of 98%. It is not altered by the food intake, so you can achieve a steady state concentration, but then again, that will take at least 1 week. Compared to posaconazole, it has less liver function abnormalities, and it causes QTC narrowing instead of QTC prolongation. Again, it can be a first-line therapy if amphotericin B is not available.
Yes, madam.
Combination therapy is something which needs to be tried, especially in an infection where there's high mortality. Multiple proposals have been liposomal amphotericin B with echinocandin or with azoles and many other combinations. But again, the most preferred one is a use of echinocandin along with amphotericin B. There is guidance from the European microbiology group and microcyst study group, again, underscoring the huge importance of using liposomal amphotericin and be upfront. It has to be at least 2 to 3 weeks initial therapy, followed by a consolidation therapy, which could be up to like many months. So you need to keep the patient under regular follow-up. Adjunctive therapies that could be tried. We have done it in some of our like leukemia patients, use of hyperbaric oxygen, but there is no no randomized studies proving that. We can use colony stimulating factors, granulocyte transfusion. Sometimes we give in our neutropenic patients, and a topical antifungal therapy, as Dr. Sanjay mentioned. I want to show this study to underscore that it's a preventable disease. It's a retrospective analysis from Fortis Hospital in Mumbai, where they kind of looked at all their patients, 5,000 patients who were admitted during the admission up to May of 2021. And they had a strict glycemic control endocrinology group that made the glycemic control possible, and a strict steroid stewardship. They had a 10-day steroid protocol, and they did not find any mucor cases in that hospital, despite a lot of cases happening around in Maharashtra. Although the limitation of study, they did not mention the follow-up period. So again, I just want to bring this to the attention of the panel. There are so many unanswered questions. We see COVID-19 mucor in patients who are not diabetic or not on steroids. So are we missing something else, like indigenous medication, other medications like vitamin C and zinc? We know that zinc increases iron absorption. Is it antibiotic overuse? Azithromycin has shown to be an independent risk factor for COVID-associated aspergillosis. So is it related? Does it have a similar association in mucor? Supply chain problems, effect of variants, geoclimatic conditions, as I mentioned, and like a nice kind of article on how the possible hypothesis, and then why we are seeing Rhino orbital cerebral disease in a COVID patient who have lung involvement, lung damage. Is it related to more expression or utilization of more expression of GRP in the nasal epithelium, or it's more inflammation related to the variants? What are the predictors for mucor in COVID-19? We need a case control study to see among my patients with COVID-19 who are at risk for mucormycosis, and how many of our late mucormycosis cases are healthcare associated, especially when we are seeing this large number of patients. And is it the time to think about combination therapy when we see high mortality? Again, summarizing, it's an increasing public health problem. Understanding pathophysiology is key to preventive and management strategies. As all my late colleagues have mentioned, it's a difficult diagnosis to make. Rapid worsening within hours, it can spread to adjacent organs. High variability with antifungal therapy. It needs a multidisciplinary approach. It's not infectious disease, or it's not ENT, or it's not radiologist. You need to talk to each other, as you all are doing. And it has associated with high mortality, and chance of breakthrough infections are a possibility that needs to be kept in mind when you treat this mucormycosis patient. With that, I will finish, and I will hand it over to Dr. Iyer. Thank you.
Thank you so much, Dr. Teny, Gupta, and Srinivasan. We've gotten a few questions so far, and so one of the questions we have got is, I think it was Dr. Teny, you had mentioned that, sometimes it's hard to track in India currently what the case rates are of mucormycosis. Could you use the drugs used to treat mucor as a proxy in India?
Yeah, again, that's a good question. Again, I don't know. I think they're the central ministry is kind of distributing the drugs depending on the case loads being reported from the states. Of course, if the ideal number is not available, then that can be utilized. But again, the correlation between I would rather use the number being reported to the center rather than the actual utilization, because there could be so many factors that will be playing a role, whether actually the patient getting it and things of that state. So again, if there is nothing else is available, then that could be used.
I actually just wanted to ask, what is the role of SARS-CoV-2 antibodies? Does it always mean that the patient has been infected with COVID, or does it, in India, majorly we are using Covishield vaccine. So some of the patients we are seeing anti-spike, which is specific to COVID, Covishield, and also the presence of SARS-CoV-2 receptor binding domain antibodies. So should we focus on the RBD antibodies? Is it of any significance to say that the patient has been infected with COVID?
That's a good question. I don't think the although this has like come in one of the discussions as well, because you tend to see positive results in patients who got the vaccine. I don't think so one thing that could be helpful to see whether the antibodies are against the vaccine or against the virus is looking for the nucleocapsid antibodies. Again, the receptor binding domain antibodies could be present in both these two categories, and it may not be useful. So I would specifically look for the nucleocapsid antibodies to see whether was it the real infection versus immunity from the antibody. But again, I'm not sure what type of antibodies that we are using in India at this point of time.
Unfortunately, we are not able to source, at least in Bangalore, the anti-nucleocapsid antibody. So what we have is a spike protein antibody and a RBD antibody. So these are the two things which are available to us right now.
Yeah, in that case, it may be difficult to kind of make that distinction. And yeah.
Thank you. We have a question from Dr. Gali, one of our global health colleagues at UCSF. And his question is, do you have any recommendations for dosing amphotericin B in patients with renal insufficiency?
Yeah, that's always a challenge when you give a nephrotoxic agent. So again, so what we normally tend to do is that we tend to give the higher dose upfront. If the patient has any chronic impairment, you can use the maximum dose that has found to be effective is 10 milligram per kilogram. But most of the patients develop nephrotoxicity. So the kind of the global consensus is to utilize 5 milligram per kilogram. So you carefully monitor the kidney function, and if the kidney functions, you feel that the kidney functions start to get worse, and you can reduce it to 3 milligram per kilogram, and then continue at that dose. And again, if it's still a problem, then maybe we may have to be forced to stop the drug at that point of time. I think in that context, it's very important to have an azole based drug also in combination with amphotericin B. So that's always a challenge, right? So there is maybe a lot of interruptions in real life with amphotericin B. So at least we have one active drug which is kind of there in the patient system. So that would be my recommendation.
Thank you. And follow-up question regarding medication safety. For Dr. John or anyone on the panel, do you have any advice for providers who are managing patients as an outpatient for effective stewardship of steroids? I think, Dr. John, you cited a study where just about 34% of the patients were on a so-called appropriate steroid dosing. What's the ongoing guidance right now? You know, as a rheumatologist, I write a ton of prednisone, and we're always worried about the long-term complications, trying to get patients off. But when you're balancing treating COVID-19 and the risk of mucor, what kind of guidance could you offer to doctors?
Again, that's a tough question, right? It has to be taken into each patient's context, because sometimes we may have to give steroids because the patient developed an organizing pneumonia or similar associated lung problems which require steroids. So again, I would say the golden rule has to be like as short as possible, depending on the individual patient's condition. So again, I think the only data that we have for COVID-19 management is the 10-day the recovery trial. So again, that is the kind of seems to be the standard, but again, every patient is different. So again, as much as short as possible and lower duration. Again, it's not only the duration, it's the amount of drug they are getting. As I mentioned, seems to be a positive correlation. So lowest dose possible, shortest duration of time possible.
Do we have any more questions from our attendees?
Yeah, feel free to ask.
Doctor, yeah, if I may ask Dr. Sanjay, like, because again, for a clinician like me, where the question is how aggressive the surgery should be, right? Again, this is like a very disfiguring condition, orbital involvement, the involvement of, or early part of the orbital involvement. So what criteria do you set before like taking the patient for like a disfiguring surgery, like an enucleation? Is there any, do you use frozen sections more commonly, or you tend to weigh on like MRI imaging more commonly? Is there any, what was your experience and thought on that?
So basically, we don't do enucleation. It is exenteration, meaning you remove the globe until the periosteum, some of the bones also. So we actually remove in toto. Uh, the criteria could be probably how much globe is involved, whether along with the sinuses, whether the globe is involved, whether there is a visual potential for this patient. So if there's no potential, probably I don't think we are going to save the globe or the surrounding structures in the orbit.
Thank you.
In general, when you get to that stage of disease, what has your experience been in that, given that you're sort of doing a total exenteration, disease probably at that time is already in the pterygopalatine fossa and then has maybe potentially gone in the epidural space or potentially cavernous sinus. So you can go up to a certain edge, but beyond that, it is sort of on the other side. It's on the neuro side of the house, which you obviously we don't go into and resect. What has your experience been with even with the exenteration? Are we able to obviously lose the vision, but are we able to save the patient typically?
Yes, yeah. We would, if we are adopting exenteration as a surgical approach, yes, we are able to save the patient. And with successful antifungal therapy, we are able to. Unfortunately, with exenteration comes a host of problems. When the patient actually breathes, eats, and all, that area actually bulges. There may be foul smelling from that area, so it's not very pleasant for the patient. So we just give the option to the patient that this is the situation, whether you want to go for it or not.
In your literature, what are the trigger points for going for this very disfiguring, very extreme surgery? Are those well defined and evidence based, or is it like people's experience that is guiding them right now?
Right now, I think it's the people's experience. As more and more cases come, as more and more surgeries are being done, I think probably we can. In fact, the paper which was published about 3 days back, it was a consensus paper of all oculoplasty surgeons in India, what they would probably do. And based on that paper, exenteration was not a primary option. So most of the disease which was extra orbital was probably saved by the FES, and in only very serious cases, exenteration was done.
Yeah, that was the question that kept coming up on the conferences that I've been with KEM and with Sir Gangaram and other hospitals. What should be the trigger point for such extreme cases? And everybody sort of tries to be as conservative as possible, do functional endoscopic surgery, debridement. But what tips you over is somewhat variable among hospitals and among practitioners.
There's no uniform one-stop solution for all this, because even among the practicing surgeons, it's not like he does, I don't do, that kind of thing. It depends on many factors: the patient's systemic status, what the patient can do, what is the post-op, what's the psychological thing he can afford. Because it's a long drawn process. It's not like you do go clear it up and that's the end of the story. That's not so. So we have to take into various factors, and also the social stigma, especially in the Indian society. So that also plays a role in whether we want to go ahead and do it.
Yeah. Yeah. I mean, India right now has enough number of cases and enough variability in the practice, and the imaging manifestations of the disease are fairly well defined. We can kind of tell what regions are involved, what regions are not involved by the disease. Just good record keeping can actually get you the answer as to what works and what doesn't, where we are being over aggressive, where we are being under aggressive.
Yeah,
So
agree.
just a collection of all the data and experience base from different tertiary care hospitals within India would go a long way in coming up with those trigger points.
Correct. So probably next few months we can have some kind of a guidelines when
That's
to
right.
actually surgically intervene, and when
Yeah.
to probably.
In fact, India should be the country issuing the guidelines to the rest of the world, because they have the experience in managing such a large cohort of patients.
On that note, maybe Sanjay and Teny, you want to tell us about what the plans are for the Mucor, especially the questions that you asked at BMC. I know both of you were involved in writing that protocol, which is going through the ethics committee in Bangalore Medical College, which has a record number of 300 patients.
Wow.
Yeah, I think when I look at the studies from India, what we lack is, again, my biggest question as a clinician: who is a patient who is at risk for developing mucor? Many of these environmental factors may be the same, but why certain patients on steroid develop the disease and why certain other patients do not? So is it the dose of the steroid? Is it the duration of the steroid? Is it other factors like role of other antibiotics? So I think first of all, what we need is that case control study. If you look at the studies from India, it's always comparing COVID-associated mucormycosis with non-COVID associated mucormycosis. So I think it has to be COVID-associated mucormycosis versus other patients who were diagnosed with COVID but did not develop mucormycosis. So I think that will help us answer. And secondly, again, it's a great point that Dr. Sanjay and Dr. Gupta mentioned. Again, who are these patients who need aggressive therapy, right? So again, looking at those specific factors of patients who had a worse progressive disease, what are the predictors of progression? What are the predictors of high mortality? Those things may help us a long way in understanding and managing the next epidemic. And in terms of the management, we definitely need, again, surgery being so mutilating, we need to have better combination of antifungal agents. Still, the global guidelines say use only one antifungal, because even amphotericin B, it's not a 100% effective drug. So you're looking at giving a drug which is not kind of, again, when you have a gram-negative sepsis, give this antibiotic, it will work. But it's not the same case with amphotericin B. And with a disease which is so advanced and angioedema, we need to have at least some sort of randomized trials to look at those issues as well. I know it's a challenge even in US to do that, but at least whether these patients will benefit. And echinocandin, it's a very safe drug. It's like a huge safety margin. So that is something that we need to think. And again, I'm happy to help with that, but that's, we have a huge opportunity that Dr. Gupta mentioned to further understand, explore this disease.
Mhm.
The challenge is, sorry.
Oh, go ahead, Dr. Srinivasan.
The challenge is to actually obtain the amphotericin. So that was the challenge. So that is why alternate drugs were there, and the bridge therapy. And as Dr. Gupta was mentioning, some of the patients we actually tried the retrobulbar or injections with amphotericin to probably salvage this eyes or salvage the globe. In some cases, it did help when FES was done completely, and probably there was some kind of orbital wall involvement, then these patients could be salvaged. So the question is antibiotics, the supply and demand. The demand was so huge and the supply actually didn't match it. So that was the challenge which we faced. So coming to whether one kind of antifungal works or the other kind of works, if we do have adequate supply, probably we can try out all these things. But when there's a paucity of all these drugs, then it really becomes a challenging issue at the ground level.
Yeah, if I may add to that, I think I totally agree with you. I think the supply has to be really good. One thing that we more use with the amphotericin B in our center is because once the drug reaches a good level, it has a good tissue concentration. So even if you are unable to give the drug daily, a thrice weekly regimen is what, like Dr. Iyer might know more. Like, is sometimes most of the time we end up the patients, like giving the patient after 1 or 2 weeks of therapy, you can switch it to a Monday, Wednesday, Friday regimen, or even like a Tuesday, Thursday regimen, instead of completely taking off the amphotericin B. Like the case I showed, I was very interested because first of all, amphotericin B was not the first choice of drug. I don't know whether it's because of the supply or because it was, again, they did not think about amphotericin B giving upfront. Secondly, the duration was so short. And we saw that in that patient, he had a progressive disease few weeks later. So again, duration of therapy and like appropriate combination all might be helpful. And if the what do you call, the amphotericin B is available, I think one combination could be an azole plus an echinocandin. Whether that also is beneficial, that needs to be tried.
Mm-hmm. We have one more question, and then we can try to wrap up the panelists. So have there been any new drug development to treat mucormycosis, especially with the onset of some like drug-resistant mucor coming up? Anything that you know of, Dr. Teny?
Yes, there have been like few phase 2-3 clinical trials going on, and unfortunately we are not part of it. I know that I think UCSF or one of the UC systems they are utilizing that. There have been like few interesting drugs. Hopefully that will show some promise. But again, it's not available everywhere, even in US. But there is some new antifungal agents, and I was when I was reading more into the pathogenesis for pulmonary mucor, the use of anti-cancer drug glittertinib that inhibits. Dr. Iyer may be able to tell me more about that because it specifically it blocks the integrin beta 1. And again, I was thinking similar lines. Is there any anti-GRP78 that would protect from the Rhino orbital disease?
Right. Thank you, everyone. It's we've gone a little bit past our time, but thank you so much to the panelists, Dr. Rajiv Gupta, Dr. Teny John, and Dr. Srinivasan Sanjay for taking time to describe and lecture us on the different aspects of mucormycosis. We really appreciate it. Thank you, Dr. Subhash and Iyer, for helping moderate the session. And feel free to email or reach out to the Telavaid team if you have any other further questions on mucormycosis. We can try to put you in touch with some of the panelists to answer your questions.
Thank you
very much.
Thank you very much. Okay. Bye.